this blood pressure. If you see the European Society, it will be classified here as an elevated blood pressure. But according to the American guidelines, it will be here, a stage 1 hypertension. It is some differences, but the management will be the same both for the American and the European guidelines. So the question is, what will be our management? Do you treat all patients with this new entity, the elevated blood pressure? So it's clear when you have hypertension, you must put the patient under treatment regardless of the cardiovascular risk. The big question remains about this patient with elevated blood pressure, and to treat or not to treat, it depends. It depends on what? I will respond you later, but let's see together how is the incidence of cardiovascular disease by systolic blood pressure. As you see here in these figures, here that outlined that the incidence of cardiovascular disease trend to increase with the increasement of systolic and diastolic blood pressure. And patients and individuals with elevated blood pressure, they can have a large burden of cardiovascular events that can happen. Approximately 3% of events can be observed in this population. The question, is there really a benefit of lowering blood pressure in high cardiovascular risk patients with elevated blood pressure? And the response is yes. Why yes? Why yes? Because it is greatly proven by many trials, especially the ESPRIT trials, which is conducted in 2024, that demonstrate that when you opted for a strict control of blood pressure, less 120 versus 140, we can reduce both major cardiovascular event and death. So, to treat or not to treat elevated blood pressure, you must assess the cardiovascular risk using either SCORE2 or SCORE2 AOP, and also the SCORE2 diabetes also was validated for the patient which were diabetes. Just one mention for the Tunisian context, we have elaborated our proper score that we call it global risk score. It's similar to SCORE2 OPS, and it is a useful tool that we use it to assess this cardiovascular risk. So, when you return to our patient, he is an elevated blood pressure, and when you classified him, he was at high cardiovascular risk. So, what will be the management on this situation? The guidelines are clear here. When you have a patient with elevated blood pressure, first of all, we must search on conditions that classified it as a high cardiovascular risk, especially the established cardiovascular disease, a moderate to severe chronic kidney disease, a diabetes, a heart failure, and in absence of this condition, you must calculate the SCORE2, SCORE2 OPS, and SCORE2 diabetes. When it is high, more than 10%, pharmacological treatment is indicated if this elevation persists more than 130/80, despite 3 months of lifestyle. For the American, it's the similar, but the American preconize lifestyle duration of between 3 and 6 months. It is the same management like the European guidelines. So, our patient, after 3 months of lifestyle measurement, his blood pressure is maintained at the same level. So, what do you prescribe? Monotherapy, dual therapy, triple therapy? What do you prescribe? Mono, dual? What is for dual? What's dual? One, dual. One, dual. No, the guidelines say that for patients with elevated blood pressure, you must initiate with monotherapy is preferred, either also for the American adult in patient with stage 1 of hypertension, between 130 and 139, you must initiate with a single first monotherapy. A last case of 16-year-old man, it is an accountant, he presented for routine follow-up of diabetes and elevated blood pressure. He have blood pressure, diabetes, 2 diabetes. He has dyslipidemia. He has under metformin, simvastatin, and valsartan. At exams, his blood pressure is 150/19. We confirmed this by EBPM. His BMI is 24. He has mild retinopathy, left ventricle hypertrophy at echocardiography, ejection fraction 70%. His glycated hemoglobin mildly altered, high, 70.2. He has macro-ALB, LDL cholesterol high, and GFR is about 50 milliliters per minute. So, as a summary, we are in front of uncontrolled hypertension in a diabetic patient at stage of nephropathy and a high global cardiovascular risk with presence of target organ. So, should we change the current medication? Of course, yes, because our patient has 3 cardiovascular risks which are not at the optimal objective. So, of course, we emphasize on lifestyle measurement, weight loss, diet, exercise, activity, and we recommend to switch from the monotherapy to a double combination with this double association, irbesartan, amlodipine, the Aprofor 145. Why this choose? Because as you know, in the guidelines, when you have a hypertension, you must start with the low doses of double combination therapy, either ACO or RB association inhibitor and calcium channel blocker or diuretic. So this was supported by the results of several studies that have been done to prove the superiority of combination therapy as compared to monotherapy. And the fact to using lower dose of each individual blood pressure lowering agent, which may reduce the side effect. In addition, many studies also emphasized of the benefit of association, the double combination, and especially the single pills combination to improve the adherence to treatment and to have a decrease of cardiovascular event and reduce of all causes of mortality. So, which double combination therapy to prescribe? As you see, there is many combination, and the guidelines are clear. They give us the choice between either prescribe, initiate the treatment with ACO inhibitor or RB inhibitor, and calcium channel blocker or diuretic. So, when you saw the literature, we see the result of this meta-analysis. As you see, they include a huge number of patients, and they tested 11 single pill combination. As you see, all combinations are started. There is the amlodipine, valsartan, irbesartan, amlodipine, but the conclusion of this meta-analysis that the RB and in addition to the calcium channel blocker combination has the better advantage than the other single pills combination in terms of systolic blood pressure and diastolic blood pressure. So in our cases, we have opted for the association of an antagonist of a receptor blocker, the irbesartan, because we know that the effect of irbesartan in reducing cardiovascular risk, especially in the hypertensive patient with diabetes, he has very efficient in reducing the micro-ALB. He also improved all metabolic parameters, and he was associated to the decrease of the cardiovascular risk. In addition, there is strong evidence of the irbesartan in the diabetic nephropathy. As you see, there is many results that approve this and demonstrate that irbesartan has a renoprotective effect. He delayed the chronic kidney disease progression and the micro-ALB. So, when you have a patient which has type 2 diabetes with hypertension and early nephropathy, irbesartan is especially supported. Why you have also choose to combine it, the irbesartan with a calcium channel beta blocker, and especially the amlodipine, because we know that the amlodipine also have a synergic effect on renal function. He improves the glomerular filtral flow, and also has a patent action on vasodilation of the renal arteriole, and also has this characteristic which was outlined in this study published in 2023, saying that the amlodipine reduce the inter-individual blood pressure variability more than the other class of drug. As you see in this study, we compare all anti-hypertensive stat, and you know that the blood pressure variability, it is a characteristic which was expose the patient to more cardiovascular risks, more event, more stroke. So the amlodipine reduce this inter-variability pressure. All studies are in accord that with using this double combination, amlodipine and irbesartan, we effectively lower blood pressure, exhibit renoprotective effect. Some Tunisian trials that are conducted in Tunisia. The first trials is the HX study, which the objective is to try to study the efficacy and tolerability of irbesartan and amlodipine combination in the management of hypertension in Tunisian patients. This is the design of the study. We have compared 3 groups. The first group are newly diagnosed of hypertension. The second group is a patient who are not controlled under monotherapy, and the third group is a patient which are non-controlled under dual therapy. And all these patients was put under Aprofor 135. And as you see in the follow-up, we notice a great reduction of systolic blood pressure at 12 weeks for both the groups, also for the diastolic blood pressure. And it is fantastic here, as you see, 96% of patients at 12 weeks have a controlled hypertension when you use this double combination. And this control of hypertension was seen regardless of the dosage, 155, 30, 35, all the dosage can reach this great control of hypertension. And for the tolerability, we have not seen many side effects. So this study shows the excellent efficacy and tolerability of this double association. Another also trials, which was also conducted in Tunisia, when the objective is to try to see is the old versus the new blood pressure target achievement under irbesartan amlodipine combination in the Tunisian context. For the design of the study is similar to the other design. 3 groups were compared. All of them are received the Aprofor. And here also, we noted that at each visit, we have a great number of patients that improve their blood pressure and achievement hypertension, blood pressure control. Yes, unless the target, we achieved the a better control when we use the old versus the new blood pressure. So our patients also have another problem, which is the hypercholesterolemia, which is not well controlled. So we decide to switch from simvastatin to Tavastor, which is atorvastatin 40 milligrams, because you know that there is a benefit of effect of LDL reduction, and lower is better in terms to reducing the cardiovascular event. So for our patient, he is at high risk, so he isn't at the right target. So you must intensify the statin, and we will put it under atorvastatin 4 milligrams to get a better control of his LDL cholesterol. And don't forget also the diabetes. He was not very well controlled, so we added for him an SGLT2 inhibitor or semaglutide. If the patient, in our case, isn't obese, but in case of obesity, you can add the semaglutide. As you see in hypertensive patient with diabetes, the glycate hemoglobin target must be less than 7%. And why not to add for this patient with chronic kidney disease an SGLT2 inhibitor to improve the outcomes. So, to take home message, an integrated approach to the management of the patient with high blood pressure. In case of elevated blood pressure, an antihypertensive treatment may be indicated for patients at very high risk if this elevation persists despite 3 months of lifestyle. In case of hypertension, the immediate initiation of antihypertensive treatment is recommended regardless of the patient's cardiovascular risk. The use of single pills combination should be more rigorously implemented into our daily practice. Cardiovascular management is a multi-factor cardiovascular risk factor optimization in order to reduce the residual risk and optimize patient outcome. I finished to say that earlier is always better, and patient and physician inertia are really issue we must be aware of. So guidelines, yes, but they must be oriented and tolerated to our real life. So before I finish, I want to invite you to our Tunisian meeting, our 45 National Congress that will be taken in 2021, 22 November in Tunisia. You are welcome, and thank you for your attention. Thank you. Is there some question? Okay, so thank you very much for the audience. Yes, how? Non, c'est obligé. Comme une autre présentation. Obligé.
السلام عليكم. Hello everybody. يلا دكتور محمد لو سمحت.
السلام عليكم. السلام عليكم ورحمة الله وبركاته. ازي حضراتكم يا دكاترة؟ أنا محمد الشامي، كانتري مانجر شركة رمسة. سعيد جدا بلقاء حضراتكم النهارده. عندنا محاضرة اليوم مع دكتور حاتم. يمكن دكتور حاتم غني عن التعريف، أنا مش هقدر أعرفه، ولكن أنا هعرف شركة رمسة لحضراتكم. شركة رمسة شركة ليبية، وكيل حصري لشركة بكسيمكو فارما. بكسيمكو فارما شركة انترناشونال موجودة في أكثر من 70 دولة حوالين العالم. مقرها الرئيسي في دكا بنجلاديش. موجودة في السوق الليبي من حوالي سنة 2018. واحد من أشهر الأدوية اللي في رمسة هو الفرنتس، فرق كربوكسي مالتوز، وده الفرق كربوكسي مالتوز الوحيد اللي موجود في ليبيا. عندنا بورتفوليو مغطي حاجات كتير جدا جوه أمراض القلب، زي الكاينيكسيا آزا ريفيروكسابان، أو البايزوران كأولميزارتان مع أملودوبين، أو الروستين كروزوفاستاتين، والجارديان 10 والجارديان 25 كإمباجلفلوزين، والجاردي ميتل اكس ار 25 على 1000 و10 على 1000، والسيماجلوتايد الوحيد في السوق الليبي اللي داخل بصوره شرعيه بكولد تشين، الريجلوتايد از جي ال بي 1، واخيرا وليس باخرا الفيفانتا كسايكوبتريل مع فالزرتان. ويمكن دي المحاضره اللي الدكتور حاتم هيكلم حضراتكم عليها. شكرا لكم.
السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بكم مرة ثانية. احنا يعني محاضرة خفيفة ظريفة اندارت الساعة 3 اليوم صباح، يعني please I will do my best, right? So we have very important treatment, what we call ARNI. It's a new approach, perhaps. So it's angiotensin receptor neutralizing inhibitor. I believe nobody of you want to see his cardiac patient that end with heart failure. It's a catastrophic, as also we know. So we can briefly come with definition of the heart failure. And the ASC, they say the heart is a clinical syndrome characterized by typical symptoms, breathlessness, ankle swelling, and fatigue that may accompanied by signs like elevated GVP, pulmonary crackles, and peripheral edema, caused by structural and functional cardiac abnormality, resulting in reduced cardiac output and or elevated intracardiac pressure at rest or during stress. ACCF and the AHA, they say the heart failure is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. Is it common heart failure? It's a common clinical condition, as you know, of you knows that. This fact, the prevalence is approximately from 1 to 2% of the adult population in developed country, with the prevalence resulting in more than 10% among persons 70 years age. So this is a disease of age. As the age is going up, as the incidence is increasing as well. The incidence over 870,000 new cases of heart failure are diagnosed annually in the States. At the age of 45, lifetime risk of heart failure taught age for 75 or 95 years range at least up to 30% to 42% in a white man and women, and from about 20% to 46% in black men and women. The mortality rate, of course, it's high. The patient with the chronic heart failure has a 50% 5-year post-diagnosis. Yani once you diagnose your patient at 45 years, imagine that at 5 years, half of your patient will be lost. So what's the objective of our treatment in heart failure? Of course, you want to improve the clinical status of the patient with heart failure. I want to improve the functional capacity and the quality of life, and prevent the hospital admission and reduce mortality. Of course, you are familiar with this. Maybe some of them are old studies, but the trials evidence for mortality benefit of drug in heart failure. In April, okay, candesartan, beta blocker, and aldosterone blockers with this well-known study, as you know. In April, in Solvit trial, consensus trial, Charm is very famous in candesartan. Of course, there are many years until we reach another drug as promising as a prognostic result expected. BRADAM heart failure trial, it's prospective comparison of ARNI. ARNI is angiotensin receptor neprilysin inhibitor with ACE inhibitor to determine impact on global mortality and morbidity in heart failure trials. It's a new day in heart failure, really. It's a step closer to taking the failure out of the heart failure. Sacubitril, it's a neprilysin inhibitor, and it's an antihypertensive drug used and combined with valsartan. A novel treatment option for heart failure, a combination drug, sacubitril and valsartan, approved under the FDA priority in July 7, 2015. This is ARNI, this is the drug code, LCZ696. As we said, that it is a combination of angiotensin receptor blocker and inhibition of neprilysin. Why we have to do this? Sacubitril, neprilysin inhibitor, valsartan, angiotensin 2 receptor blocker, fixed dose combination in one tablet. It has a dual action, emphasize protective pathway. يعني عندنا نحن two pathway اللي هو الناتريتيك peptide. I think you want a natriuretic peptide process to go on, not to stop it. And the RAS system, it's a bad thing. You have to stop it. Okay? So this combination will enhance the protective pathway and suppress the harmful pathway of the RAS. Okay? This is the mechanism, as we can see here. So the effect of the angiotensin 2, this is, we have to block it to prevent the vasoconstriction, to prevention increased blood pressure, sympathetic tone, aldosterone, and fibrosis and hypertrophy. On the other hand, natriuretic peptide will degrade it into an active fragment, so we have to block it. Once we block it, so we have to the natriuretic peptide will increase, it will make vasodilatation, or the blood pressure will reduce, sympathetic tone will decrease, aldosterone level decrease, fibrosis, hypertrophy, all of them are decreased. So at this time, we will have a neurohormonal balance. What's the indication? Indication to reduce the risk of cardiovascular death and hospitalization for heart failure in a patient with chronic heart failure, NIHA 2 and 4, and reduce the ejection fraction. What's the contraindication? Hypersensitivity to any component, history of angioedema related to previous ACE inhibitor or Arab therapy, concomitant use of ACE inhibitor, not recommended for a patient with severe hepatic impairment. What's the dose and how to administration? The recommended starting dose is 51 milligram twice daily. Double the dose after 2 to 4 weeks to the target maintenance dose, which is 97/103 twice daily as tolerated by the patient. Reducing the starting dose to 24 of this to 26 milligram twice daily for the patient not currently taking an ACE inhibitor or Arabs or previously taking a low dose of these agents. In the renal impairment, mild to moderate, and GFR is more than 30 ml. No starting dose adjusted is required. And severe, we have to reduce the dose. In the hepatic impairment and the mild hepatic impairment, no starting dose adjusted is required. Moderate and severe, and moderate we have to reduce, and severe is not recommended. Pregnancy, ARBs should be used during pregnancy, should not be used, sorry, in pregnancy because they can reduce fetal renal function and increase the fetal and neonatal morbidity and death. We can compare sacubitril valsartan with enalapril, and both of them are sharing the same side effect. Angioedema, it's 0.5 sacubitril with valsartan, where its point is less in enalapril. Hypotension is more in combination, and the impaired renal function is more with the enalapril is 4.5%. Hyperkalemia, they are near each other, 12 and 14. Cough, 9 and 13, also near. Drug interaction, a concurrent use of with an ACE inhibitor is contraindicated because of the risk of serious angioedema more often in black people. The potassium-sparing diuretic may lead to increased hyperkalemia, especially in patients with renal impairment, diabetes, and hypoaldosteronism. NSAIDs, non-steroidal anti-inflammatory, may lead to increased risk of renal impairment, and lithium increase the risk of lithium toxicity. What's caution? Observation of the sign, the symptom of angioedema. It lowers the blood pressure and may cause symptomatic hypotension, especially in patients who are volume depleted or salt depleted. We have to monitor the renal function and the potassium level, as we said. So, Bradam heart failure trial, prospective comparison, as we said, of ARNI with ACE inhibitor to determine the impact of global mortality and morbidity in heart failure trial. It's a new day in heart failure to stop closure to the taking a failure out of the heart failure. This is published in the New England Journal, this study. The targets, the largest clinical trial ever conducted in heart failure, it's about 8,442 patients over 47 countries. They stopped the test early due to the compelling efficiency. Risk of cardiovascular was significantly reduced. The key efficient outcome, the primary endpoints, cardiovascular death, heart failure, and hospitalization. And the secondary endpoint, all-cause mortality, time to new onset of atrial fibrillation is decreased, the time of first occurrence of protocol-defined decline in renal function. They have early termination while stop following our recommendation from the data and the safety monitoring committees. The trial was stopped 6 months prior to its scheduled completion. Specifically, number of cardiovascular death was achieved and exceeded. A treatment difference were seen early and effect size randomized stable during the trial. Analysis of the patient with event at the time of the closure, but unknown at the final meeting, DSMB meeting, increased the magnitude of the final result. Here, if we can compare the enalapril with the salvartan, this is the cumulative risk is much lower and combined to the enalapril. The study shows also death from cardiovascular less 20% as compared with the enalapril, and the 19% sudden death decrease, 16% death from any cause. The first hospitalization for heart failure 21%. The total number of the ER visits significantly decreased up to 30%, and the total number of the hospitalization decreased up to 23. If you can, the percent, this angiotensin receptor inhibitor with also the renin, decrease in the mortality significantly. We can compare ACE inhibitor with the angiotensin receptor blocker, significantly decreased more than 20% in this combination. It's a nice combination. As we know, the ProBNP is a prognostic and diagnostic indicator. It's much decreased in this combination as compared to the enalapril. Update guidelines for الأرني. الأرني is recommended class 1 level A from patient with heart failure less than or 40% to reduce cardiovascular death and heart failure hospitalization. should be initiated in a state of ACE inhibitor or ARB in symptomatic heart failure patient, NIHA 2 and 3, when the drug is tolerated. Start after hemodynamic stabilization, may begin during or shortly after hospitalization. We should avoid the concurrent ACE inhibitor use and wait 36 hours before you start this treatment. We have to monitor blood pressure, renal function, the serum potassium regularly. We should consider, it's a class 2B actually, in selected heart failure, mild reduced ejection fraction and preserved ejection fraction patient. Benefit modest but possible in those with heart failure near 40%. In conclusion of the article, the results of Bradham heart failure shows significant reduction in the primary composed endpoint, cardiovascular death, and all-cause mortality in a patient receiving LCZ696. In comparison with those receiving enalapril, suggests that the drug could replace the ACE inhibitor and the ARBs as a first-line therapy in heart failure reduced ejection fraction once regularly approved is obtained. Our conclusion is the RAS blockage combined with the NP system augmentation represent a novel approach of patients with heart failure. Sacubitril with valsartan is indicated to reduce the risk of cardiovascular death and hospitalization in a chronic heart failure, NIHA 2 to 4, and reduce ejection fraction. It may consider instead of an ACE inhibitor or ARB for first-line treatment of heart failure and reduce ejection fraction. Hypotension and angioedema could be problematic. And thank you so much. I'm sorry. معلش دكتور محمد لو سمحت فينك. تحب تقدم المسابقة؟ خلينا هو دكتور محمد مقدم لك مفاجأة في مسابقة عليه سؤال، هو اللي حيجاوب الأول هو اللي حيكسب؟ حضرتك أنت اللي مديريته ولا أختار أنا حد بالعيلة مثلا ولا حاجة؟ مدام وبنتي موجودين هنا. What is the percent of the reduction of total heart failure hospitalization and cardiovascular death in Vivant? I shouldn't say that يا محمد. أي حد يجاوب حيكسب النهارده. Percent of reduced total heart failure, hospitalization, and cardiovascular death. أي محمد. أول واحد حيجاوب حنقول له صح. كم؟ 21 and cardiovascular death. ها؟ 42. لا دكتور علي شكلك انت اللي حتكسب. اقرب واحد للدكتور. يا كمان دكتور محمد اقرب واحد. النص بالنص ساعات ترى. هي عندكم ليكتشر بسيط عشان مش نعطلوا الناس. Thank you so much. I'm sorry. I apologize for delaying. And so, نعم. اسمك دكتور لو سمحت؟ تعال يا ابني تعال. شنو الجائزة يا دكتور؟ شنو الجائزة؟ هو ريدمي باد تابلت 8.7 مبروك. Congratulations. بس عاوزين له ورد لو سمحت. صديق. تمام. أنا خلصت كده. لا هو علميا اتكلم في الرعاية اتكلم يعني.
خلصنا الكامبين سمبوزيوم. عندك محاضرة. السلام عليكم. Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, it's really an honor for me to be moderating this session in advanced heart failure, acute and advanced heart failure. Our first speaker, Dr. Hadi Skouri. Can you hear us, Hadi? Hadi?
I'm hearing you.
Thank you. Okay.
I'm hearing you.
Perfect.
Are you hearing me well?
Yes, we can. Loud and clear. Dr. Hadi Skouri is a good colleague of us. He's a senior advanced heart failure consultant, cardio-oncology. He's a leading advanced heart failure in Sheikh Shakhbout Medical City in Abu Dhabi. He was involved in the first LVAD implantation in the Middle East in Lebanon. He's the chair of the Lebanon Heart Failure Association. He was very keen to attend, but unfortunately he is not well health-wise. In spite of all that, he's joining us virtually, so we appreciate all that. His talk is going to be tips and tricks in acute heart failure. Hadi, go ahead.
Thank you, Muhammad, for the kind introduction. Are you seeing my slides?
Yes, we do.
Okay, thank you, Firas. So first of all, I would like to thank the Libyan Cardiac Society for the success of this conference and for hosting the 4th Pan-Arab Heart Failure Conference, and a thank for the organizing committee of the Pan-Arab Heart Failure Conference and the Middle East Heart Academy for the kind invitation. As you have told Muhammad, I was enthusiastic to be with you, but for some sickness I'm not able to. Hopefully we'll make it next time. So these are my disclosures, and my topic for today is about acute heart failure tips and tricks. We'll start with a case scenario, then we'll go over some fundamental concepts of definition in acute heart failure from pathophysiology to management, including some what to do and what to avoid with some take-home messages. We start with a case scenario which most of you encounter in the emergency room or in the inpatient services. Elderly patient with heart failure and improved ejection fraction. He has multiple comorbidities on optimal guideline-directed medical therapy, presenting with a high blood pressure, desaturation, respiratory distress, and signs of volume overload. So you see a chest tachycardic with some LVH and a chest X-ray of congestion. So this patient is going to be treated, but before we reach the options of this patient treatment, we'll go over acute heart failure, and at the end we'll tell you how he was treated. So first of all, acute heart failure can be present in whether in heart failure with reduced, preserved, and mildly reduced ejection fraction. Usually, most of the admissions with acute heart failure to the hospital are acute decompensated heart failure, where the patient has already known heart failure. And in 25%, it's a de novo heart failure, where the patient was not previously known with heart failure, and this was his first admission with acute heart failure. But up till now, with some of these recent trials that were conducted in acute heart failure, still there is a high 2-month mortality and rehospitalization. By 2 months, 40% of these patients will be either readmitted or die within these 40 months. And this is one of the important things that we aim at reducing. Second thing, the more the patient is hospitalized per year, the more the lower the in-hospital survival, as well as the poorer the quality of life of these patients and the higher the intensity of care. This will lead to frequent hospitalization, frequent acute heart failure decompensation, leading to advanced heart failure, where the management is in a way different, and it's beyond the scope of this presentation. When we say acute heart failure and the patient is admitted, we don't mean only the inpatient from the ER till the admission to the hospital and discharge, but also we should include the post-discharge phase, because these are patients at vulnerable risk to re-hospitalize or die within the first 2 to 4 weeks after discharge. And not only that, but also pre-hospitalization, there will be asymptomatic congestion if we monitor these patients adequately and or hemodynamically with some telemonitoring devices, we can detect these patients before they reach the stage of hospitalization and acute heart failure. And this is where we should manage our patients to prevent admission with acute heart failure and to prevent readmission after an acute phase. The second thing that I want to highlight on is the pathophysiology of acute heart failure. This pathophysiology is diverse because we have different substrates from structural heart disease, whether heart failure with reduced preserved hypertrophic cardiomyopathy, valvular disease. In addition, there should be some triggers that decompensated the patient, like high afterload from elevated blood pressure, ischemic events like acute kidney syndrome, arrhythmias like atrial fibrillation, infection, sepsis, progression of renal dysfunction, and non-adherence to medications. And there are some amplifying mechanisms, whether at the myocardial level, renal, vascular, and neurohormonal activation. So by having this substrate with some of the triggers and some of the amplifying patterns, the patient will progress from an asymptomatic to asymptomatic acute heart failure decompensation with congestion and volume overload. And this is why we have always to address and look for etiological factors that exacerbated or decompensated the patient and address them. And for this reason, and because of the diverse pathology of acute heart failure, I don't believe that one therapy will fit all patients, and always we have to address therapy according to the patient profile as well as comorbidities. And this is why in most recent guidelines, they indicated that we should evaluate the severity of congestion and adequacy of perfusion when the patient is admitted with acute heart failure, and I will dwell on that in the next couple of slides. Also, we should address the precipitating factors, as I told you, from this diverse etiology, as well as we should initiate treatment. First of all, stabilize the patient within the first 48 hours, then initiate therapy pre-discharging this patient and continue optimizing this therapy post-discharge. So if we divide the patients, this is important to hemodynamically profile the patients according to the congestion status and perfusion status. So when we say congested, meaning the patient is wet. When we say the patient is not congested or euvolemic, then the patient is dry. When he has good perfusion, the patient is warm. Low perfusion, the patient is cold. And according to this, depending on the clinical evidence and bed assessment, clinical assessment, if we have evidence of congestion or perfusion, we divide the patient into warm and wet, cold and wet, cold and dry, and warm and dry. From most registries, as you can see here in red, most of the presentation, up to 70%, 75%, they present warm and wet condition. And why this is important, this classification? Because this will help us when we clinically know the patient's condition. This will be translated into hemodynamics, because a warm patient has a normal cardiac index or approximately normal cardiac index, while a congested patient will have high filling pressure, high LVDP, and high wedge. Similarly, for cold and wet, they have a high wedge with a low cardiac index. And this is important because according to this classification, we can initiate therapy for these patients. So, for example, for high wedge pressure, we have to reduce filling pressures by giving diuretics or vasodilators. For low cardiac index, we have to give either inotropes if the blood pressure is low, or afterload reducers to reduce afterload and reduce blood pressure and reduce systemic vascular resistance, thus increasing cardiac index or cardiac output. So by dividing these patients into these congestion perfusion status, we can know their hemodynamic profile as well as how to treat these patients. One important thing that I have to highlight is the congestion mechanism. Not all congestion is due to volume overload and increase in extravascular volume and increase in sodium and water reabsorption, because there are other different mechanisms of congestion which are called redistribution of blood or volume of blood that I dwell on in the couple slides. This fluid redistribution can be at the arterial system where we have ventriculovascular mismatch, or at the venous system where we have vascular and ventricular mismatch. So at the arterial system, when we have elevated systemic vascular resistance from any cause, this will increase blood pressure and decrease systemic vascular resistance. So the left ventricle finds it difficult to eject blood to the aorta. And by that, blood will flow back to the less resistant circulation, which is the pulmonary circulation, causing congestion and pulmonary edema, even the patient is euvolemic or mildly hypovolemic. And in these patients, if we just give high doses of diuretic to treat congestion, the next day the patient will develop acute kidney injury or elevation in creatinine just because the patient is intravascular depletion, because he was at the beginning mildly hypervolemic or euvolemic. Just this is a distribution of blood to the less resistant system. So the treatment will be arterial vasodilators, reduction of blood pressure, plus minus low dose diuretics. At the same time, the venous system, we have the veno-ventricular mismatch. We know that the splenic venous circulation is a high capacitance circulation where normally it contains at least 1 to 2 units of blood or around 500 cc of blood. Whenever we have an acute increase in sympathetic or renin-angiotensin-aldosterone activation, we'll have venous capacitance that will be decreased via venoconstriction, and this will, in a short period of time, push blood from the splenic venous system to the heart, causing high pressures and high volume overload. And in this case also, venodilators plus minus diuretics will be the treatment of choice in these patients. The fifth thing that I would like to highlight on is systolic blood pressure. Admission systolic blood pressure is important for in-hospital prognosis as well as post-discharge prognosis. The lower the blood pressure, the higher the in-hospital mortality and the higher the post-discharge mortality. And this will help us in risk stratifying the patient and aggressively treat the patient during hospitalization. When it comes to the management of acute heart failure, if we look at the 1970s guidelines and the 2022 guidelines, actually the treatment is still the same with in the acute phase or the first 48 hours. Diuretics, vasodilators, inotropes if needed, in addition to temporary mechanical circulatory supports in case we have cardiogenic shock, and this is beyond the scope of our management. The new things that were added is to initiate a guideline or contemporary guideline-directed medical therapy before discharge or early after discharge, and follow these patients up in this vulnerable period, the first 1 month in a cardiac service or heart failure service, to optimize therapy, reduce hospitalization, and reduce mortality in these patients and have a better outcome in these patients. The second point that I have to highlight on is congestion. The presence of congestion on a chest X-ray if there is no congestion, this doesn't mean or doesn't rule out acute heart failure, because in a chronic heart failure patients, we have lymphatic drainage in the pulmonary circulation that will reduce blood pressure, and this will reduce pulmonary congestion, and they can present around 40% of the patient, they have a high watch pressure above 25 with a more clear lung. At the same time, venous congestion will not show in chest X-ray in some cases, and and in such cases, most of the patient will present with cardiorenal syndrome. So that the assessment of congestion is not relied only on the symptoms and the physical examination and weight of the patient, but also we should rely on biomarkers like natriuretic peptides and ultrasound of the lungs, which is a new method to check congestion and follow up on congestion, to check ascites and pleural effusion, because ascites increases intra-abdominal pressure, and this will cause cardiorenal syndrome and resistant to IV diuretics, and to check inferior vena cava showing venous congestion in these patients. So this is just a figure to show you B lines of the cardiac ultrasound, and we should train ourselves for that, especially who are dealing with acute cardiovascular care, as well as IBC assessment in these patients. The second point is, the following point is about biomarkers. We have troponin and anti-proBNP. And one thing that I should remind you of, that biomarkers will make bad doctors worse and good doctors better, which I mean that we should not rely on biomarkers in managing these patients. And I mean that because elevated natriuretic peptide can be related to heart failure, but it has other causes, whether cardiac and non-cardiac causes, that can cause elevation of BNP or anti-proBNP, that we have to consider them. So always we have to rely on the clinical symptoms as well as the biomarkers. And one thing also, this is from the Reality AHF, that we should not wait for biomarkers to start IV diuretics in the emergency room, and we should improve door to furosemide time or door to diuretic time, as we do that with door to balloon time in acute coronary syndrome or ST elevation MI, because the more we prolong or not administer a patient with IV diuretics in the emergency room, the higher the on-hospital mortality rate in these patients, and the higher the complication of pulmonary hypoxemia and intubation or endotracheal intubation for these patients. The second one is troponin. Not every troponin is an acute coronary syndrome and acute heart failure, because a troponin can be related to high filling pressures, apoptosis, subendocardial ischemia that will lead to release of troponin. And this is very important, because we should not only think of troponin as ACS in acute heart failure, and when the troponin level is static, then this is a chronic myocardial injury, and this should not tell us that we should directly take the patient to the cardiac lab and do coronary angiography and possible PCI, because we should not do harm. We should first do no harm on these patients, and this is because whenever we have acute heart failure, we have venous congestion, we have multi-organ dysfunction, and giving contrast for whether cardiac MRI, coronary CT, angiogram, PCI, or for other looking for infections, CNS, etiology, or pulmonary embolism early on will lead to acute kidney injury. And this is showing that if we give patient contrast when the patient is congested or intravascular depleted, this is where the high risk of contrast-induced nephropathy. So we have to keep the patient euvolemic unless there is an emergency with ST elevation MI and we need to open the culprit lesion in these patients. So when we treat heart failure patients, we should look, as I told you, on the congestion status and perfusion status, and accordingly, if the patient is wet and warm, we need to give vasodilators and diuretics, and if they are dry and cold, then we have to, if they are wet and cold, for example, then we have to treat them according to blood pressure. Less than 90, they need inotropes and diuretics. More than 90 or 100, we need vasodilators and diuretics in this situation. Always, we have to keep in mind, and I urge you to go over the ASC 2021 guidelines, how to diurese the patients, always with IV diuretics at least 1 to 2 times the daily oral dose given IV. We have to monitor the patients, whether with urinary spot sodium or with urine output every 6 hours to see if there is more than 100 or 150 cc per hour. If there is no adequate diuresis, then we have to escalate. And then if it's still there is no adequate diuresis, we have to combine diuretic therapy like thiazide, like diuretics, to increase diuresis in these patients and reach euvolemic state the earliest possible. Another point to highlight is that not every rise in creatinine is acute kidney injury, because if we think so, then every drop in hemoglobin is acute hemorrhage. And always there is a conflict between the nephrologist and cardiologist regarding creatinine and EGFR in these patients with acute heart failure. But we know that
Hadi,
venous congestion can contribute
can you please?
venous congestion can contribute to that too. And this is why pseudo-worsening renal function is important to determine,
Hadi,
because
can
this
you-
will help us in
Hadi?
lowering, not treating these patients in a different manner or give these patients fluids. One point to highlight is intra-abdominal pressure and EGFR, which should be taken into consideration to reduce ascites in these patients. I will not go over in-hospital worsening heart failure, which is important
Hadi,
too.
can you
And I
summarize,
will
Hadi?
end here. Yes, maintaining and optimizing guideline-directed medical therapy is important. So we should not stop medications in the acute phase, and we need to make every effort to start medications on discharge, because guideline-directed medical therapy initiation, other than diuretics, have been proven to improve early and late outcome. And my take-home messages is diversity of mechanisms in acute heart failure. Always we should have proper assessment in these patients. Volume overload versus redistribution is important to determine. Persistent congestion and end organ damage are important to determine when to give contrast in these patients. Pseudo worsening renal function, we have always to think of it, because if the patient is congested, is being relieved and improving, even though with some higher creatinine, they are doing well than if they are deteriorating with giving them, administering them IV diuretics. Every attempt should be made to continue guideline-directed medical therapy, always evaluate for etiology, and initiate or uptitrate contemporary guideline-directed medical therapy immediately after stabilization. Thank you.
Thank you, Hadi. This was a great, comprehensive talk. Stay with us if you can for the discussion later. It's my great pleasure now to introduce my good friend, Professor Firas Badr, who has so many titles. Suffice to say that he was actually the director of the program of advanced heart failure in Ottawa, in the United States. Knowing his passion and keenness to improve heart failure care in the region, he moved to Kuwait, where he established advanced heart failure. Then after that, he came to Cleveland Clinic, Abu Dhabi, again establishing advanced heart failure transplant. He's a very keen educator. He's the founder of the Middle East Heart Failure Academy. He runs so many educational programs that attracts most highest caliber speakers from around the world. It's really a good mentor and a good friend. He's going to talk to us this afternoon about temporary mechanical support rule in acute heart failure cardiogenic shock. Firas. Some technical issue. While waiting, anybody got any question to Dr. Haskouri on the acute heart failure? Hadi, are you still with us? Hadi, are you still with us? You can hear me? We cannot hear you, Hadi. Maybe you're on mute.
No, no, I'm not muted. I'm not muted.
We have a technical
It's from
issue
your side.
with Dr. Firas, and we got a question for you from Dr. Salah Al-Badri from Qatar Advanced Heart Failure. So the question to you now.
Are you hearing me now? Are you
Yes, we
hearing me?
can. Can you hear us?
Yes, yes, yes.
Okay, so there's a question to you from Dr. Salah Al-Badri.
Go ahead, Salah. I'm not hearing Salah. Ahmad, are you hearing me?
My question about IV nitrate. You know, it's widely used as part of acute decompensation treatment. You know, in the 2021 guidelines, they used two trials, Elizabeth and Galactic trial, saying that they are neutral and IV nitrate is not, or they give a weak recommendation for IV nitrate. You know, here in Libya and everywhere we are using IV nitrate. What's your position of that?
Why I mentioned, thank you, Saab, for this important question, but if we go to the pathophysiology of acute heart failure, I believe still that the first 48 hours, the treatment in the first 48 hours may not reflect a treatment benefit at 3 and 6 months or 1 year post. So most of the trials, their endpoints is cardiovascular mortality and heart failure hospitalization at 3, 6 months or 1 year. And this is one of the reasons why most of the acute heart failure trials are negative. So still in the first 24 to 48 hours, we have to go with the hemodynamic profile of these patients. So if the patient has increased afterload, then we have to reduce the afterload. Otherwise, it's not only treatment with congestion, treatment with the diuretics. So we need to reduce the afterload in these patients the first 24 to 48 hours. This may not reflect into 3 months, 6 months, or 1 year mortality benefit, but it improved the patient hemodynamically and reduce hypoxemia in the first 24 to 38 hours. I still believe we should use it, even though we don't have benefit for the endpoints at higher levels. Even though diuretics, you can see that we are using it, but it doesn't improve mortality or morbidity at longer duration or 3 to 6 months after treatment.
Okay, thank you, Hadi. We're going to go to Dr. Firas' talk and we may come back to you later on. Firas, I've already done the introduction. Thank you.
Thank you very much, Mohammed. I'm just waiting for my slides to load. Apologies for the technical issues. So, Hadi gave a great presentation about acute heart failure management. My role in the next 15 minutes is to build on his presentation and focus on a specific segment of his patients. Remember the 4 quartiles of patients where 90% are wet, but 20% of the 90% is wet and cold, and then you have the 5% that are wet and dry. So the concept of cold is when people's perfusion is suboptimal. And my talk today is about these patients who are suffering the low perfusion or the patients who are in cardiogenic shock. And of course, we'll take it from there to talk about ventricular assist devices when Dr. Emil presents, and then the ultimate therapy at the end stage, which is heart transplantation. Okay, so we'll talk a little bit about the definition, classification, pathophysiology, a little bit about hemodynamic monitoring, selecting the right form of mechanical circulatory support in these patients, and then the shock team concept. So what is cardiogenic shock? Cardiogenic shock is basically evidence of hypoperfusion, meaning decreased cardiac output in the context of adequate filling pressures, meaning that this is not hypovolemic shock. It's not because of volume. The blood pressure is low in the context of low cardiac output and index, and with normal or high filling pressures. This is the classification of cardiogenic shock. And the best way to do this classification is to go from stage A to B to C to D and E. A would be people who are at risk for cardiogenic shock. People who are coming in with acute coronary syndromes, for example, or who have chronic heart failure and they're coming in with acute decompensated heart failure. Anybody who is potentially susceptible to going into the shock state. B would be the beginning, somebody who started to show these heart failure signs and symptoms, maybe starting to have evidence of hypotension, but not necessarily hypoperfusion as evidenced by systemic findings and normal lactate. And then C is when you start having hypotension with evidence of hypoperfusion. Clinically, the patient is mentally not normal. You shake their hands and they're cold. Their urine output is low. You check their kidney function and it's rising. Their serum lactate is rising. This is the classic. And D is somebody who's deteriorating with these classic findings. Of course, if you have pulmonary artery catheterization, then you can really assist your diagnosis with invasive hemodynamics. And then E is somebody who's really about to arrest. Very, very sick person, very disturbed hemodynamics, and very high serum lactate. Next. So, as you all went through medical education, you've learned that when cardiac output drops, the body compensates by vasoconstriction, by increasing vascular resistance. Because remember, the goal of the cardiac output, the goal of the heart as a pump, is to create enough blood pressure to perfuse different organs. So organs see blood pressure. They don't know what the ejection fraction is. They don't know what the heart pumping function is. They know blood pressure. When the blood pressure drops as a result of the cardiac output dropping, the blood pressure is a function of the cardiac output and the vascular resistance. When the blood pressure drops because the cardiac output is dropping, the other component of that blood pressure, which is the vascular resistance, will go up to compensate. So the body vasoconstricts to compensate. This is why we all learned growing up into the medical field that if you have hypovolemic shock or if you have cardiogenic shock, there is vasoconstriction, unlike septic shock, for example, or neurogenic shock. What happens is, as you move forward in the pathophysiology of cardiogenic shock, patients stop vasoconstricting, and because of the new endotoxins and inflammatory markers and the acidosis that builds up, that vasoconstriction fails, and patients go into a phase of vasodilation, or what we call paralytic vasodilation, which means that despite the pumping function being so low, the body is not able to compensate by vasoconstriction to keep that blood pressure up. And no matter how much you try to vasoconstrict these patients with medications, with things like norepinephrine or vasopressin or dopamine or whatever you use, you will not be able to get that blood pressure up. And that's where you need to interfere early with mechanical circulatory support to reverse that cycle, because the body itself is not able to compensate anymore. Next. So, things that could favor cardiogenic shock in the context of heart failure relative to acute MI, because like I said, it can happen in the context of heart failure, it could happen in the context of acute MI. The blood pressure and heart rate may be relatively preserved with a narrow pulse pressure, favoring more heart failure. Of course, this is not comparing heart failure cardiogenic shock with STEMI cardiogenic shock, because everybody will recognize STEMI, hopefully. This is about heart failure cardiogenic shock with maybe non-STEMI associated with cardiogenic shock, so with a acute coronary syndrome cardiogenic shock. Signs of chronicity, so if the heart is remodeled like we mentioned in the previous session, this suggests that this is chronic heart failure now deteriorating into acute heart failure with cardiogenic shock. RV function will likely be impaired because this is a chronic heart failure situation. And then, of course, filling pressures tend to be higher. Next, please. So therefore, having good cardiac ICU monitoring with pulmonary artery catheterization is really, really helpful in the management of these cases. Just by a show of hands here, how many people use Swan-Ganz catheter in their units or in their hospitals? Swan-Ganz catheter management in acute heart failure. The majority don't use it. Not available. So Swan-Ganz catheter is not available in Libya? Okay. Next. So this is a study from a single US center, 520 cardiogenic shock patients, and it just highlights that patients with acute MI deteriorating into cardiogenic shock generally tend to be a little bit older with more traditional risk factors compared to heart failure patients. And of course, heart failure patients in these contexts end up with more LVAD and transplant as solutions to the problem, because everybody knows that these are chronic heart failure patients, and the fact that they're presenting in acute cardiogenic shock just means that their disease process is progressing more to the end stage. So PA catheter will differentiate cardiogenic shock from other forms of cardiogenic shock. It will unmask this quote-unquote normotensive cardiogenic shock when the systolic blood pressure is actually more than 90, because now you have hemodynamics. You can measure by the PA catheter that the cardiac output is low and that the filling pressures are high. It will help you assess if the right-sided pressures are elevated to indicate that the right side is not working very well. It will guide the use of vasoactive therapies, and it will help you choose the right form of mechanical circulatory support. You've seen this already. Always, always put your patients in a category from a volume standpoint and from a perfusion standpoint. They're either hypervolemic or euvolemic. They're either hypoperfusing or well perfused. Some helpful parameters, if you're looking at the RV, for example, again, this is in the context of having pulmonary artery catheterization. If your CVP, right atrial pressure, is more than 2/3 of the wedge pressure, then this is definitely a bad RV. And then, of course, the other parameter I would like to highlight here is something we call pulmonary artery pulsatility index. If you leave today with these simple hemodynamic parameters, you can really help your patients and look much smarter when you're rounding on these patients in your coronary care units. But pulmonary artery pulsatility index is simply your systolic PA pressure minus the diastolic PA pressure over the CVP. And when that's below 2, it means that the RV function is not very good. When it's below 1, then the RV is really in trouble. Another important hemodynamic parameter, very, very easy to calculate, is mean arterial pressure multiplied by cardiac output divided by 451. Cardiac power output was believed to be the strongest independent hemodynamic correlate in hospital of in-hospital mortality in patients with cardiogenic shock. So very, very strong correlation between cardiac power output and outcomes in cardiogenic shock patients. Simple to calculate. Again, you need a method to calculate cardiac output. If you don't have the invasive method, there are now non-invasive ways to calculate cardiac output. They're not going to be as accurate as the invasive ways, but at least better than nothing. Quickly on inotropes and vasopressors. People keep quoting SOAP2 study as the study that told them that norepinephrine is better than dopamine in the context of cardiogenic shock. Just a couple of points here. The SOAP2 study was not actually a cardiogenic shock study. It was a shock study. And the percentage of cardiogenic shock patients in it was only 17%. So, and the study was negative. And as you heard already today, when the primary endpoint is negative, you can't make conclusions from subgroup analyses. In the subgroup analysis of this, it appeared that norepinephrine was better than dobutamine. But again, this is based on a negative primary endpoint in a study that was not designed to be primarily a cardiogenic shock study. So don't conclude from this that norepinephrine is better than dopamine in the context of cardiogenic shock. As a matter of fact, in the context of cardiogenic shock, what you need is neither one of these. You need a true inotrope. And true inotropes would be things like dobutamine or mirinone. When it comes to mechanical circulatory support, and I'm going to have to kind of go relatively quickly through this, it's about choosing the right patient, the right device, the right time, and the right setting. Again, by a show of hands, how many people here see or use in their practice intra-aortic balloon pump? Intra-aortic balloon pump? Okay. Impella is not available here. ECMO? ECMO single center? Okay. So in Tarablos. So this is the intra-aortic balloon pump. The intra-aortic balloon pump works by augmenting the diastolic blood pressure. The intra-aortic balloon pump is a simple pump to use. It's widely available throughout the world. And what it does, it improves coronary perfusion because it inflates during diastole and it deflates during systole. As you know, coronary perfusion happens during diastole. We used to use intra-aortic balloon pump in all of cardiogenic shock patients before we started to have better devices for mechanical circulatory support. It's a well-known technology and it's familiar to interventionalists and actually a lot of invasive and sometimes heart failure doctors place intra-aortic balloon pumps in heart failure patients. In the SHOCK 2 trial, there was no difference between using intra-aortic balloon pump or standard therapy in patients who came in with acute myocardial infarction. In that case, 70% were STEMI patients. But of course, in that study, 85% of the cases had the balloon pump placed after reperfusion. So this could actually explain why there was no benefit for the balloon pump over the standard therapy in these patients, because once you reperfuse patients with acute MI, there is arguably no benefit to add pump support necessarily. The study here was negative in that regard. Impella is another percutaneous device. We call it microaxial flow pump that can be used to support patients with cardiogenic shock. In the Impella initial studies, it was shown to increase cardiac output significantly and also reduce filling pressures, because this catheter that I showed you goes into the LV, takes blood from the LV, and then pumps it distally. So there's an active motor in the catheter that pumps the blood distally. And by that, you help the failing heart, with an additional pump that only works through a single catheter. Again, something that made its way through many, many centers around the world, but admittedly expensive and with some complications related to it. Impella versus intra-aortic balloon pump in acute MI studies was not very impressive. It was relatively neutral. And then we had the danger shock study. The danger shock trial looked at Impella versus standard therapy in patients with acute myocardial infarction and resulted in significant reduction in all-cause mortality. But there has been a lot of criticism of the trial because the trial was highly selective. So to apply the evidence, you need to have the same characteristics. This was only in STEMI patients. Systolic blood pressure was less than 100 or on vasopressor support. Lactate was more than 2.5. LVEF less than 45. No RV dysfunction, no out-of-hospital arrest, no coma on arrival. So you really have to apply the criteria strictly. And when the trial was analyzed very carefully, there were some specifics related to the trial that I'm not going to go into in great deal of depth now, but suffice it to say that there was just as high rate of complications as it was beneficial in the trial, and it was really marginally positive. So why am I saying this? Because this is, again, another form of support that in the context of acute MI did not seem to help as much as it could potentially help in heart failure-related cardiogenic shock. You guys owe me 5 minutes. ECMO basically is cannulating the femoral artery and femoral vein. And when you cannulate the femoral artery, femoral vein, you have this external pump. And with the external pump, you take blood from the femoral vein, pump it back into the femoral artery. Of course, this direction of blood is going against the normal direction of the pumping. So it tends to increase the afterload a little bit on the heart. And in that case, you have to manage patients in a way that unloads the heart. So commonly, we use the ECMO in the context of a balloon pump as well. Again, ACLS shock is a trial that showed ECMO not beneficial in acute MI patients versus standard of care. And as you can see, the theme here is that in acute MI patients, temporary mechanical support did not have the same strength of evidence that we expected it to do. And perhaps the only benefit with putting all these studies together, perhaps it's beneficial in some select STEMI patients with cardiogenic shock. I say this because in the context of heart failure-related shock, so heart failure not related to acute MI, we believe that these devices may be of more potential benefit than in the context of acute MI. So balloon pump versus Impella versus ECMO, they all tend to improve the blood pressure because the balloon pump improves the cardiac output just a little bit, Impella more, and then ECMO, of course, provides you probably with the most significant cardiac output increase. Cardiac power output is not increased much in the balloon pump, but increased in Impella and ECMO. And then importantly, afterload or wedge pressure is not affected necessarily by the balloon pump, afterload is, but the wedge pressure is not affected much by the balloon pump, is decreased by Impella, and it actually tends to be increased by ECMO. So what you need to do to summarize the evidence with mechanical support is that in patients with evidence of acute coronary syndrome and shock, a lot of these patients will improve without any mechanical support. And unfortunately, a lot of them may end up dying whether or not you do mechanical support. The key is trying to identify the 5 to 10% of those patients who need the mechanical support and who will actually do well receiving it. And then, of course, the last thing that is worth mentioning here is the importance of the team. Centers vary. You know, there are the centers that do not even have the cath lab capabilities, all the way to the centers that have all kinds of invasive capabilities, including all forms of mechanical support. And the idea here is early recognition of shock patients, and when these capabilities are not available, transferring the patient to a center that potentially has these capabilities. At least one form of mechanical support should be present in big centers so these patients can have their lives saved as opposed to dying with cardiogenic shock. And this all is supposed to happen within 60 minutes, by the way. So the shock team is the key to improving the shock outcomes. The shock team is the cardiac intensive care doctor, the cardiac surgeon, the interventional cardiologist, as well as the heart failure team. So in summary, the incidence of cardiogenic shock, heart failure is rising relative to that of cardiogenic shock of acute MI. There are unique epidemiologic and pathophysiologic differences between cardiogenic shock, heart failure, and cardiogenic shock, acute MI. Invasive hemodynamics are extremely helpful to differentiate between patients. Early identification, triaging, and management is key in improving outcomes. We need more studies for mechanical circulatory support in heart failure patients with cardiogenic shock, just like we had them in acute MI with cardiogenic shock. The Middle East Heart Academy obviously has a busy calendar throughout the year. You've seen these on Hadi's slides. We have the updates on cardiomyopathy conference in December, and then we have our most important conference in January, the Middle East Heart Failure Conference. The abstract submission is still open until November 15. Submit your abstracts because winning abstracts actually get financial awards, and not only that, can get travel awards as well. And all of these conferences, also things like the Cardiorenal Forum and the Cardio-Oncology updates are also happening throughout this academic year. If you register yourself as a member of the Academy, you could potentially have a chance to attend or participate in these conferences and all of the other Middle East Heart Academy activities for free. Thank you.
Thank you for us. It's my pleasure and to introduce the next speaker, Dr. Emil Najjar. He's a consultant in advanced heart failure in Karolinska University Hospital, Stockholm, Sweden. He's the director of the VAD program. He's certified in medicine, echocardiography, etc., etc. To me, the most important thing for you to know that this doctor has lived all his life in Libya. He studied medicine in Libya. He loves Libya, and he loves all Libyan food. And he's trying to do whatever he can to pay back the country that actually he lived in with. He will kindly talk to us this afternoon about a durable LVAD therapy introduction. Emil, the floor is yours.
السلام عليكم يا جماعة، وأنا أشكركم كثير على إتاحة الفرصة، وشكرا دكتور محمد على المقدمة. Thank you Firas and Ayman for the kind invitation. I see that many tired faces. I'll try to do my best to be concise, and I have one mission today, is to help you identify patients with advanced heart failure so you can refer them to a specialized center. So today I'm going to talk about durable LVAD. LVAD is left ventricular assist devices. So here are my financial disclosures. So let's start by talking about advanced heart failure. Advanced heart failure in the publications or in the literature, you might find different terms meaning the same thing: advanced heart failure, or terminal heart failure, or end-stage heart failure, or refractory heart failure. All of them mean the same thing, which is advanced heart failure. And advanced heart failure has been defined in a document from 2018 that it is an advanced stage of heart failure with severe symptoms. And in that document, they told us that advanced heart failure may be left ventricular failure, right ventricular failure. It may be HFrEF, it may be HFrEF or HFpEF. So there are different kinds of conditions leading to advanced heart failure. And if we look at the different classifications used to define advanced heart failure or severe advanced heart failure, the Americans use the classification A, B, C, D. We usually mean D. NIHA classification 3B or 4 are the ones with advanced heart failure. But we usually, when we communicate with the surgeons, we usually use the Intermax classification. Intermax classification is a classification derived from the American LVAD registry. So we usually mean class 2 to 4 to mean advanced heart failure. And what you need to know that the patients with heart failure, they will usually progress to advanced heart failure. So we need to identify patients transitioning to advanced heart failure. And we can, why do we need to identify patients with advanced heart failure? Because advanced heart failure is associated with high mortality. And the mortality is usually between 25 to 75%, depending on the region, on the country, on the available therapies. And the studies about prognosis are very limited. The one on the left side is the rematch study, which is the only study included heart failure NIHA class 4, and the patients in 2001 were divided to continue with medical therapy or to add left ventricular assist device. At that time, only 8% of patients with medical therapy survived at 2 years. So the survival at that time was really bad. If we look at the European guidelines for treating heart failure, HFrEF, as you all know, we start with the 4 medications, and then we go to ICD or cardiac resynchronization therapy, and the next level we should consider patients for mitral clip if they have severe mitral regurgitation, or we should go to transplantation or left ventricular assist device. So these are the 3 options in cases of advanced heart failure: mitral clip, or left ventricular assist devices, or transplantation. But what is the right time to send patients for LVAD therapy or transplantation? We should always pick up the right time. They shouldn't be too healthy, and they shouldn't be too sick with kidney failure, liver failure, and it's too late to survive. So I think this is the most important slide for you, young cardiologists, to know what are the clinical symptoms and signs that the patient has transitioned to advanced heart failure when you see them in the ward or in the emergency. Repeated hospitalizations is a marker, is a signal of poor survival. Worsening of kidney function, worsening of liver function, they develop low blood pressure, and we need to reduce the heart failure medications. We need to give them more and more Furix to get euvolemia, and then they develop ascites, which is a sign of right ventricular failure, or maybe ICD shock. So these are the clinical symptoms of signs of worsening. And if you think that there are too many points, well, our colleagues from Denmark and Harvard in the US, they suggested you need to remember only 3 things. Repeated hospitalization as a sign of advanced heart failure. Number 2, you need more and more diuretic. Number 3, they develop low blood pressure. And when we talk about mechanical support, so the patient may go home with mechanical support, we have different options. In patients with only failing left ventricle, you use the left ventricular assist devices. If you have failing left and right, you can use biventricular support, but they are more complicated, or you may use total artificial heart. You think this is science fiction? You look very depressed, guys. So, a typical left ventricular assist device, the patient will be operated with a pump in the left ventricle, but the energy needed to operate these pumps is very high, so they have to wear 2 batteries and a controller. This is a typical patient with left ventricular assist device. They can travel, they train regularly, and they are mobile. And the thing about left ventricular assist devices is not new. In 1967 was the first transplantation, heart transplantation. The first LVAD implantation was in 1963. The older devices, they were really huge in size, mechanical valves, and they were pulsatile, pulses, while today's left ventricular assist devices, they have continuous flow. The flow will continue all the time, regardless of the pulse. So if they get cardiac arrest, you cannot check their pulse or measure the blood pressure. The only device available is HeartMate 3, and it can give you pump up to 10 liters per minute. And the question, why do we need LVADs in patients with advanced heart failure when we know that transplantation is probably much better? Well, first of all, shortage of organs. Number 2, the long waiting time. In Germany, I come from Sweden, in Germany the waiting time is 5 to 7 years. In Sweden, it's between 6 and 12 months. So we have shortage of organ, number 2, long waiting time, and number 3, LVAD technology has improved, and they are now competing with transplantation regarding survival. What do I tell the patients when we talk about LVADs? What are their benefits? Number 1, improved survival. Number 2, improved quality of life, despite going around with batteries and controller. And number 3, reduced heart failure symptoms. Let's start with, go back to the older generation, the older one, the huge ones from 2001. They included more than 120 patients, all of them NIHA class 4, and they divided patients into those going to only medications or medications plus LVADs. And at that time, with the older generation, the survival at 2 years with only medications was only 8%. So many of the patients on only medications died at that time. Only 23% of LVADs patients survived. At that time, the LVADs gave the patients additional 8 months of survival. If we talk about now, the pumps now in 2021, 2025, you can see that the survival is more than 80% at 2 years. In 20 years, we have succeeded in improving survival with LVADs from 23% to more than 80%. And if we look on the right side, on the survival with the transplantation, and on the left side, survival with LVADs, in the first few years, they are competing on survival. They are very similar in survival, transplantation and LVADs. When we talk about 5-year survival with LVADs, 5-year survival now is about 60%, okay, in all ages. And so the first one, they improve survival. The second one, do they provide patients a good life with a good quality of life? Well, what we know that the symptoms, the red column means that NIHA class 4. So at the time of implantation, many of the patients had NIHA class 4. With time, there was an improvement of NIHA classification. And about the quality of life, yes, there are many studies that have shown that the patient think that LVADs improve their quality of life despite the complications. Who is telling me, Firas, and all the other colleagues what to do are the guidelines, either the European guidelines or the American guidelines. And the European guidelines from 2021 is telling us that we can use LVADs in patients with advanced heart failure either as a permanent therapy or as a bridge to something else. The American guidelines as well is telling us that we should use LVADs. In Sweden, we have recently completed a new study comparing patients with advanced heart failure, dividing them into 2 groups, the new medications against new medications and LVADs. 74 patients are already included, and next year we will do the analysis. What about the contraindications, like right ventricular failure, neural status? I think as a general cardiologist, you shouldn't go into details. You should know how to identify patients with advanced heart failure and leave the rest of the job to heart failure specialists. How do we do the operation? You can do the traditional operation or probably minimal invasive. This is the LVAD team at Karolinska. In the center, the hardcore team, cardiologist, thoracic surgeon, anesthesiologist coordinator, and then there are many other specialists. So it's really a challenge for structures to have such therapies. But there are Yes, they improve survival, they reduce symptoms, improve the quality of life, but they are associated with high risks. Early, you have the risk of thrombosis, stroke, and bleeding. Later on, risk of right ventricular failure and aortic regurgitation. Risk of admissions to the hospital, so still there despite LVAD. How do they die? They die probably mainly of neurological incidents like bleeding or stroke. So my take-home message to all of you, advanced heart failure remains a major clinical challenge with high mortality. High mortality. Once guideline-directed management therapy is insufficient and you need to remove much of the medication, it's time to go to advanced heart failure therapies. You should identify patients early and send them to advanced heart failure center. Today's LVADs are much advanced and they do improve survival. The question I finished my presentation, but the question in countries like Libya, where can I send my patient? To which center? This is number one. And the second one, should I establish an LVAD program? I think the answer is that you should start by establishing heart failure clinics. And then when you are done with the basic therapies, then we should think about LVAD therapy. And thank you.
Thanks a lot, Emil. That was really great. Now it gives me a great pleasure to introduce the next speaker, Dr. Mahmoud Abdu. He's Libyan through and through. He's an advanced heart failure consultant. He's actually director of the LVAD program in Emory University. He's also he's a associate director of the fellowship program there, and he's also associate professor in that university. He's a very keen physician, Libyan physician abroad to help. He's been a regular attendee of the Libyan Cardiac Society, and this afternoon he's going to talk to us about the latest updates in heart transplantation. Mahmoud, floor is yours.
Shukran. Thank you very much, Muhammad, and assalamu alaikum, everyone. I hope everyone is awake. I know it's been a long day. You've been hearing about heart failure all day long today. And, you know, over the last 3 sessions, my colleagues and friends, Hadi, Firas, and Emil have went through advanced heart failure, a little grim of a topic. I'm going to kind of top it off with an introduction to heart transplantation. You know, I feel that we need to learn about these things and give you kind of the latest updates. I don't have any disclosures, but my aim for the talk today is take you through a journey historically. Where has heart transplantation began, where it is now, and where is it going in the future? What is the status of the heart transplantation in the region, both in the Middle East or Eastern Mediterranean and North Africa? So the history of heart transplantation is very interesting, and it started all back, believe it or not, in South Africa. It was December of 1967 where Dr. Christian Bernard, he's a South African cardiothoracic surgeon, he performed the first adult heart transplantation at that time that lived only 18 days and died of pneumonia. Interestingly, that Bernard did practice or did some of his training in Minnesota, the United States, along with his friend Norman Shamway. And Norman Shamway, just after 1 month of the first heart transplantation, did his first heart transplantation in the United States at Stanford University. Both Shamway and Bernard, over the next couple of years, had a lot of very not so good outcomes in heart transplant. And not until 1970, where Dr. Shamway pioneered, along with his colleagues at Stanford, the development of calcineurin inhibitors or cyclosporin, and that made a big change in the field of heart transplantation and actually solid organ transplantation in general. So this is the timeline. If you notice, I'm highlighting few green, some green and some yellow or orange, whatever that color is, stars. And heart transplantation idea was really developed back in the early 1900s. And not until 67 when Bernard and Shamway did the first couple of transplants. You notice on the timeline here in 1983, cyclosporin became FDA approved, and it was widely used as an immune suppression and actually changed the landscape of heart transplantation. And you can see throughout the years, every few years, there's some development and some advancement in the field. And I'll show you the survivals and volumes, which are very, very impressive. Which heart failure patients should be considered for heart transplant? You've been hearing this all day today, stage D heart failure, and I'm not going to go over the criteria of this. However, these are other indications for heart transplantation that are not stage D heart failure. Any patients with heart failure who had refractory VT, intractable angina with absolutely no surgical or percutaneous options for revascularization, infiltrative cardiomyopathy, sarcoidosis, amyloidosis, hypertrophic cardiomyopathy, valvular heart disease, ARVC, advanced complex congenital heart disease. All of those are other indications for heart transplant beyond stage D heart failure. Where are we today? Today, this is kind of a display of volume trends across the world from 1992 up until 2023. And you can see that North America, both the United States and Canada, both dominate the field of heart transplantation. However, since the mid-2014 or so, there's been a little step up in the volumes of heart transplant. It's estimated that almost 80 to 90,000 patients have benefited from heart transplantation across the world. And right now in the United States, where I practice, we are living in an era of revolutionized in heart transplantations and increased volume and increased hope for patients who are otherwise declared as dead and don't have any hope. And that's owed all to some adjustments in the allocation system of organs. Other factors include advancing in the technology of organ preservation, which I'm going to highlight in a few slides. The indications for heart transplant remains predominantly non-ischemic cardiomyopathy. Almost 45% of the patients have non-ischemic cardiomyopathy. Only a third of the patients have ischemic cardiomyopathy, and that has not really changed over the years. This is the trends of heart transplantation and those who are supported with mechanical circulatory support devices since the 2005 until 2024. And you can see, this is worldwide, by the way, that there is an uptake of use of temporary mechanical circulatory support prior to heart transplantation. And we have noticed this in our center, which is considered a very high volume center, is that these patients go into their heart transplant surgery well optimized and have better outcomes. Of course, there are some caveats to those who are intermax stage 1 and who are in deep cardiogenic shock, so on and so forth. What is the landscape of the region? Now, this is going to be, I warn you all, this is a depressing slide, and I apologize. However, I'm going to highlight the centers around Libya that have heart transplantation programs. We have our neighbor country, Tunis, the population of 12 million. They did 5 heart transplantations in 2024. You have Saudi Arabia, which is a population of 35 million. They did 35 heart transplantations, and this is considered the highest in the Arab region. UAE, they have a population of almost 11 million, and they did 7 heart transplants in 2024. Kuwait has a population of 4 million, and they had 2 heart transplantations. Iran has a population of 82 million. They did 150 heart transplantations in 2024. And Turkey, they have a population of 86 million, and they did 43. I was talking to Salah yesterday, Salah al-Badri, and he informed me that Qatar did their first heart transplantation in 2025, and they have an N of 1. Why am I bringing this up, and why am I showing these numbers? These numbers, if you notice, that there is a huge need. If a population of 35 million is only transplanting 30 patients in a year, or a population of 12 million and transplanting 5 heart transplants in a year, what's happening to the rest of the population, what's happening there. Where I come from, the state of Georgia, where Atlanta is, we have 2 heart transplant programs. In 2024, between both our programs, in a population of almost 10 million people, we transplanted almost 200 heart transplants. So there's definitely a need and there's a gap that needs to be filled. Volume in by itself is meaningless unless you couple that with survival and quality of life. This is a trend of survival by era, if you notice, that back in the 1900s, 1992 to 2000, is illustrated in the blue line. You see that the 1-year survival after heart transplantation is around 85%. Look at the brown line, which is the top line. This is the era that we are living in right now, 2018 to 2023. Heart transplantation recipients live around more than 92% in 1 year. What are the risk factors for 1-year survival? There's many. I'm not going to go in details about this. However, it's thought that the indication whether or not you have congenital heart disease, these usually have worse prognosis and higher risk. Patients who are on the ventilator prior to their surgery, prior cardiac surgeries, so on and so forth. I'll leave this up for a minute for you to glance on, and hopefully you will have a copy of these slides. Other factors to consider that are considered high risk for survival and within the one year after heart transplantation is patient's age. We know that the higher the age of the patient, the less likely their survival in a 1 year will be successful. The donor age as well has a lot to do with this. Kidney function and liver function are also very important factors that determine the survival after 1 year. I'm going to take you into a little bit, describe the process of heart transplant and how does it go. I like to think about it in 3 phases: pre-transplant, the transplant phase, and post-transplant. Pre-transplant, the heart failure shock and management, the evaluation selection process. The transplant phase is where the surgery happens, post-surgical care. Post-transplant, now you're talking about the allograft health and surveillance, management of complications and side effects. This is at Emory, this is the pre-transplant team. You notice that there is a lot of teams involved, a lot of people involved, not just the physicians, not the surgeons, not the nurses, but you have physical therapy, occupational therapy, infectious disease people, immunologists, nurse coordinators, psychiatrists, pharmacists, nutritionists, social worker, finance, palliative care. It's a huge team. What is the purpose of this team and what is the purpose of selection is that you want to evaluate for contraindications for heart transplant and identify them, and if they're reversible, you can make these patients qualify for heart transplant. What is the transplant phase? This is the transplant phase team, and you can see, and this is the transplant phase team at Emory, and you can see the cardiac surgeon is in the middle, intersects with all the other people around this. I'm not going to go and read them out loud for you, but you can see that how big of the team it is. The post-transplant phase, similarly, has a very huge team as well, and the patient is in the center, and the heart failure cardiologist here, along with the coordinators, primary care physicians, immunology, infectious disease, pharmacy, all are involved in this care. The complications post-heart transplant is important to recognize. There are host factors for complications like infections and malignancy, and there's graft factors like allograft failure, rejection, and cardiac allograft vasculopathy. Immune suppression is for the purpose of immune suppression is to prolong the longevity of the allograft, and these are some samples of immune suppression agents that we use. For allograft surveillance, we use echocardiography, biopsy, corneoangiogram, gene expression, donor-derived cell-free DNA, and nuclear cardiology. And this is another advancement in the field that has been recognized and has been getting a lot of traction. Infection is the most common complication, and it's very, very problematic. That's why you want these patients to be on the appropriate opportunistic infectious disease prophylaxis and proper screening for malignancy. So this is the balance between graft and host factors and longevity and survival post-heart transplant. It involves all three, but in order for that to be successful, I put all three teams on top of each other. It just highlights the importance of multidisciplinary team, or a true multidisciplinary team approach that is involving a lot of people from a lot of disciplinaries. I like to think about it as a program that has or a health system or healthcare system that has a heart transplant program actually is a pulse check on the sophistication of that healthcare system, because in order for this to work, it needs to be happening in a very solid infrastructure. It does truly take a village to make this happen. Where are we going with this in the future? You know, for programs and countries that are having already established heart transplantation programs, broadening the indication for transplant, expanding the recipient criteria, increasing the donor pool by accepting hepatitis C virus, HIV donors. Those are very important to consider. We are pushing the boundaries in organ preservation and adopting new technologies for post-transplant management. This is what we used to transfer organs from through just a ice pack. This is after a brain-dead donor. With the evolution of organ preservation techniques like the Sherba pack, ex vivo, and transmedics, we are now able to push the boundaries in organ preservation, taking these organs in a higher radius and longer distances with preservation and reduction of ischemic time, and allowing a concept called donation after circulatory death to happen. And it's been very remarkable, and the outcomes have been amazing. We are active participant in the ex vivo preserve study, and the results are looking very, very promising. New technologies for post-transplant management. I'll take an extra minute, and this is the biopsy. This is the classic biopsy that we do for patients. This is disappearing because now we are replacing that with gene expression and gene molecular expression, donor-derived cell-free DNA that can tell us if this organ is being rejected or not. A lot of integration between antibodies and mitochondrial gene expression, protein biomarkers, and hopefully one day we will get to a point where we can survey these allografts non-invasively and get rid of all the invasive techniques that carry a lot of complications. So heart transplantation is still considered the gold standard for management of advanced heart failure patients if the patient is eligible. The phases of heart transplantation demonstrates the true meaning of practicing in a multidisciplinary model. The future of heart transplantation is bright. Innovation involving organ preservation and allograft surveillance. And the main thing and the main message here is heart transplantation is underutilized in our region. We need policy, health infrastructure development and improvement, and advocacy. And I want to highlight the advocacy are key points to success. Thank you very much.
Perfect. Thank you, Abdul. Okay, guys, we've got about 10 or 15 minutes for discussion. If you've got any burning questions, please come forward.
Assalamu alaikum. My question to Dr. Najjar, as you spoke about mechanical circulatory support, we know that Egypt, Algeria, Tunisia already started their program with ECMO and LVAD in the last 2 years. Do you think this program can start in Libya in the next year or two? What's your thoughts on that? Thank you.
Thank you. I'm not that much involved in the Libyan healthcare system, but I think you are still struggling with basic heart failure therapy investigation